Okay. Well, what we'll do today is talk about a variety of syndromes that have dysmorphology associated with them and are seen in the newborn period, most of which hopefully you're familiar with. We'll talk about the findings in the syndromes as well as testing. So everybody knows what these kids have, right? Is there anyone who wants to tell us, since we all know, right? Okay, well, these babies and fetus have Down syndrome, which is going to be one of the most common things you see in the newborn. 95% of the babies born with Down syndrome will have straightforward trisomy 21, mostly related to maternal non-disjunction. As you know, there's an increased risk of maternal non-disjunction with advanced maternal age, and that's why all women 35 and older are offered prenatal testing. Only about 2% of kids with Down syndrome have mosaicism, and about 3% will have an unbalanced chromosome translocation that may or may not be inherited. From the prenatal standpoint, we have lots of findings you could see. The increased nuchal scan, you see echogenic focus in the heart or in the bowel, you can see the increased pacing between the first and second toe. Can see hypoplastic nasal bone, brachycephaly, short femurs, heart defect, and other birth defects. So there's a lot of things you can see from ultrasound. And I'm sure everybody in this group is now familiar with, besides doing invasive testing, such as amnio or CVS, there's now available the fetal cell-free fetal DNA, cell-free fetal DNA from the maternal blood to screen for trisomies 13, 18, and 21, and it's getting to be used more and more and more. So besides the typical facial features and hypotonia, the spastic tongues, and they don't really have big tongues, they just have small mouths and spastic tongues. There's an increased risk of birth defects. As they get older, most of them function in the moderate range of cognitive impairment. Many of them will not be small at birth, but they have their own growth charts because they're all smaller as they get older. And I'm sure all of you are aware that the American Academy of Pediatrics has guidelines for surveillance of children with Down syndrome. And we have a Down syndrome clinic here that doesn't see kids instead of their primary, sees them along with their primary doctor. And so you'll see, if any of us have done a consult, we always say refer to the Down syndrome clinic. They have a higher incidence of hearing and vision problems. Nowadays, of course, all newborns get screened for hearing, and they should be screened probably annually for hearing problems, and they need to see ophthalmology sometime. It doesn't have to be right in the hospital, but sometime in the first couple months, and then on an annual visit as well. Now, this baby, you can kind of see, has small features with small eyes and small jaw and kind of a prominent occiput. Here's some more pictures. There's the baby, you can see kind of squinched up. I call it the persimmon looking face, all squinched up in overlapping fingers because this baby's hypertonic. Often not much on the outside as far as birth defects, but that squinched up face and the overlapping fingers and hypertonia, and these babies are usually small at birth. So these kids have trisomy 18. So just kind of keep this picture in your mind, because a lot of people will say to me, I can't tell the difference between trisomy 13 and 18, and there's really big differences. Not every kid fits every profile, but this is the typical kid with trisomy 18, such that externally you don't see many birth defects, but you see small size and squinched up appearance, overlapping fingers, and then when you start looking inside, you find birth defects. They tend to have small features: eyes, nose, ears, mouth, jaw. And as I mentioned, they're hypertonic with overlapping fingers. They have multiple anomalies, but often they're internal. Occasionally they'll have a cleft or follicle or spina bifida, but mostly you'll see internal things such as heart and kidneys. Actually, most fetuses with trisomy 18 will miscarry, and of those that are born live, 90% of them die within the first year. They have profound cognitive impairment, those that live, and The problem is that sometimes doctors will say to the parents, well, they're going to die, so there's nothing to do. They don't all die, and the parents need to know that. They need to know it prenatally if it's diagnosed prenatally, and they need to know it after they're born. And obviously, if they're able to go home, they still need to be followed. Prenatal findings, again, you see small size. You can actually see the overlapping fingers and a whole variety of birth defects. Now, here's a bunch of babies, and you can see a lot of them will have bilateral clefts. They often have like a sloping forehead, indicative of a problem in the brain. They have Their eyes are kind of, see this lower one on the left? That's a real typical appearance of kids that don't have clefts, but their eyes look like they're microphthalmic, but they're really like deep set eyes. A lot of them will have scalp defects. I haven't really seen one with that many scalp defects, but pretty much most of them have scalp defects. Many of them have polydactyly. It could be hands, feet, one or both, all four extremities. And the males tend to have somewhat ambiguity of their genitalia or under masculinized genitalia. So this is a typical baby, and you can see this doesn't look like the other typical baby I showed you with trisomy 18. And these babies may be small, but often they're normal size at birth. This is obviously trisomy 13. I've talked on the phone with a neonatologist describing a baby to me and could tell it was trisomy 13, so a lot of those features are so specific to trisomy 13 that they're fairly easy diagnoses to make clinically. Again, like trisomy 18, most will miscarry. Again, 90% of born will die within the first year. Those that live have profound cognitive impairment. They have a lot of surgical birth defects like the clefts. And the prenatal findings include all the things that you see. You should be able to see on ultrasound the bilateral clefts. Even the genitalia would look different, polydactyly, heart and renal abnormalities, which most of the babies have. And a lot of them will have holoprosencephaly or other brain anomalies that you can see prenatally. This is a newborn up there, and then you can even see the adult. But in the newborn period, these are kids that are always small, and they tend to have rounded faces, and the big giveaway is they're kind of weak and hypotonic, and their cry sounds like a cat. So the Cri du Chat babies are small and weak, and their cry sounds like a cat. And if there's any question at all, try to get them to cry, and you will hear that when they cry. And these kids are uniformly small size. And what causes Cri du Chat is the missing tip of the short arm of chromosome 5, which sometimes can be seen with a chromosome analysis, often may need an array or fish to be seen. So a lot of the cases are submicroscopic. 90% of the kids we see are from a parent who has a balanced translocation involving the tip of 5 and another chromosome. And again, they have profound cognitive you know, if not, I'll tell you now, retiring the end of June. But when I was first doing genetics, a lot of these kids died, and it was predating the time that we gave G-tubes to kids that had. So now with G-tubes and lots of good care, they do a lot better. This is another small kid at birth. Typically these kids may have bilateral clefts, even though these kids do not. And if you look at the lateral view, you'll see that nose, and that's what they call the Greek warrior helmet. And again, these are kids that are hypotonic and weak and small. And this is Wolff-Hirschhorn syndrome, also 4P minus. Small piece of chromosome 4 at the tip is missing that can be found by just regular chromosomes, but many may be sub. So an array or fish will pick that up. Profound impairments, and actually when I say a third, like 5P minus now that we have a lot more kids that have trouble with feeding and tend to do better. But they do have profound cognitive impairments. So this is a pretty diagnosis to me. Now, not all these kids have these features. The major feature you can see being edema. Dysplasia, and a lot of these kids will be picked up prenatally. And if I tell you this is a girl, then you know that the diagnosis is Turner syndrome. So we will pick up a lot of these kids prenatally by routine ultrasound. The thing is, not all the kids have lymphatic dysplasia, and if they don't, they often don't have anything that gives away their diagnosis in the newborn period. However, if they do have the features, they should be easily recognized in the neonatal field with the that NAC is related to the cystic hygroma, residual extra skin. The kids that have a coarc, it's primarily dysplasia internally and kind of pressing against the growing aorta, so it's a secondary deformation. They're also at higher risk to have a hypoplastic left heart, which is not related to that. So if you had a little girl with a hypoplastic left heart, I'd always do chromosomes looking for Turner syndrome. The hand and related to lymphatic dysplasia, and so any of those things can be seen prenatally. They have a higher incidence of cardiac, as I mentioned. Obviously, they're at risk for anything that a boy is at risk for by just having one X chromosome, and they do have these spatial temporal and cause them to have school problems. The two most and consistent findings are short stature and infertility, which nowadays, both of which can be treated. The gonadal dysgenesis, so they don't have any eggs that work. So in order to have babies, they need to have a donor fertilized by IVF with the husband's sperm and then implanted in the woman's uterus, and then they have to be maintained during pregnancy with hormones. Now treating all these girls at a young age with growth hormone, and we actually have a Turner syndrome, multidisciplinary Turner syndrome clinic here, which I'm co-director with Dr. Chowdhury in endocrinology. This is kind of really interesting because kids that had this condition for a long time prior to finding out what caused it, and these are kids that look really, really coarse, the problems, severe seizures, and if you look at them, besides the coarse features, they're lacking hair in the temporal region. And because they look so coarse, people thought storage, so they were all worked up for storage disease. They all had chromosomes, everything was normal, and then came out with an article in the early 80s. This is a kid that we followed when I was at University of Virginia for many years. I mean, if this kid is still alive, he'd be like 30 years old or more now, more than 30. And this one on the left, this is a little girl that I saw in an outreach clinic in Virginia, and I went right away to the test that we did in those days to diagnose it because of her look. And what this is Killian-Pallister syndrome, and it's due to having 4 copies of the 12P. So not the whole 12, just the PR. And it's not really in the way that we made the diagnosis was do a skin biopsy and do chromosomes on a skin biopsy. Now it turns out that array will often arrays picking up a lot of things that we couldn't pick up before, and even though people worry about arrays missing mosaicism, this is one time, for whatever reason, it's picking it up. The reason we don't use chromosomes in the blood is that those abnormal cells die out, and that's why it's a mosaic. They don't last in the blood cells where they're in fibroblast cells such as skin cells. So that's how it took a long time before someone figured out it was a chromosome problem, because people weren't just routinely doing skin fibroblasts unless they were suspecting something mosaic. Like if you look like Down syndrome and the blood was normal, we'd go on to do skin. So that took a while, but like I said, in the early 80s there was a paper written, so now it's like 30 years ago. And here's a picture of the chromosomes of a patient that has Killian-Pallister, and that extra chromosome in between the two normal 12s is 12p. So you have one of 4 12p's, and it's only in some of the cells, not in all of the cells. So it's mosaic. So even though this is a little boy, you see these babies in the newborn period and hopefully diagnose them. Sometimes we get to diagnose them prenatally, more and more these days with level 2 ultrasounds. So he has the most common reason for disproportionate short stature, which is achondroplasia. Here's a lateral view of a boy. And achondroplasia here it's molecular labs here in OSU. They deal if one of them does something, the other one doesn't. So he does the ones for FGFR3 mutations, and the skeletal X-rays, skeletal survey, should make it an easy diagnosis. And in fact, by ultrasound, they should be able to skeletally diagnose these kids who have shortened femurs. And as you can see, they have disproportionately large heads with the prominent frontal bossing. And they can have a lot of their backs and their overbite dental things. The mom and one of the sons has achondroplasia. Here's some more pictures. On the bottom is showing you about called the trident hand, where it looks like your hand gets divided into 3 sections. That's just the way they naturally hold their hand. You can see a lot of lordosis in these kids. You can see the disproportionate short stature femurs or obvious. It's called rhizomelic shortening, when the upper arms and the upper legs are disproportionately shorter, and the frontal bossing with the upturned nose and relatively large heads. There are guidelines for following kids with achondroplasia, AAP guidelines as well, and they can get compression from the foramen magnum, so we usually do ultrasounds on them as newborns, and that will determine if they need to see neurosurgery or have more either CAT scans or MRI on top of that. So these are 2 different babies that have the same diagnosis, which you're all familiar with, is thanatophoric dysplasia. Also an FGFR3 mutation. It can be diagnosed prenatally, but if you see the baby when they're born, that's what they look like. And it's a diagnosis. They die early, but not necessarily in the first day or the first week. And that's important to remember, because one time I had a neonatologist call me and said, hey, this baby was diagnosed prenatally to have thanatophoric dysplasia by Dr. Pryor's lab, but he's not dying, so I don't know if it's the right diagnosis. Well, they don't necessarily die the first hour or the first day or the first week. So some of them have actually gone home with the parents and then died later. So just so you have a good idea that a lethal condition doesn't mean it's lethal right away. And this what they have is really underdeveloped chests, and so they die from lung hypoplasia. But some of them do better than others, and they don't live long lives. They'll all die within the first few months. So some of them will go home on palliative care. Some of them will not go home. And it kind of depends on what you work out with the family. So This is a baby that has kind of an abnormal looking skull and a beak nose, prominent eyes, and total syndactyly of the hands and feet, which we call mitten hands and feet. Here's a close-up of the hands. And you see the bones in the skull. Not only do these children have craniosynostosis, but they have underdevelopment in the periorbital region with a lot of mid-face hypoplasia. And there are gene with the picture I showed you was Apert syndrome. So hopefully every neonatologist can diagnose Apert syndrome by looking at their skulls, their heads, and recognizing the abnormalities, and then seeing the mitten hands and the mitten feet. So if you see that, just call us right away. We can also get DNA testing done, but they're real easy to make a clinical diagnosis on. And it is autosomal dominant, but most of the kids we see represent new mutations. Syndrome, which is another syndromic craniosynostosis, also caused by FGFR2, but doesn't have the hand and feet abnormalities, and tends to be a little more variable, and so you might see a parent and child affected. And sometimes we'll see a kid affected, and you kind of look at the parents, they never know, but they have just little subtle findings, and so we'll test them, and they have the same mutation. C3-Chosin is more common and more variable and generally less significant, and that's caused by a mutation in the twist gene. So a lot of times, depending on what we see, we may send for a certain kind of test that we're most suspicious of, but then say, if you don't find this, then do this test. This is all pictures of Cruzan syndrome. And some of them look pretty significant and some not so significant, but you can even see people that are way less significant than these individuals. But they tend to have the prominent eyes and the underdeveloped midface and the beak nose and an abnormal skull shape from the craniosynostosis. Most of the time they have normal intelligence. And here's some more pictures of Aperts that tend to look more significant, and the hands and feet are really the giveaway. And this is a variety of people with C3-Chosin, which can be a lot more variable. They usually have unilateral coronal synostosis with C3-Chosin. And I can't tell you, I've seen a lot of families where it's been 3 or 4 generations, but no one's ever done anything or knew anything till we see the baby. And the mom said, oh yeah, I had a funny shaped head like that too. And sometimes she still does, you know. Now this baby looks kind of wretched and awful. You might even think trisomy 18 if you see and see how squinched up the face is. And see the not only the small jaw, but the little cleft in the jaw. And the club feet's real common. And what this baby has is Freeman-Sheldon syndrome, and also called whistling face syndrome, and it's called that because they look like they're whistling. So like I said, it looks significant, but they have normal intelligence. They don't really have any cognitive problems. Most of the time it's dominant, but once when I was in Iowa, I think, I found a baby that was Amish that I diagnosed it, and you kind of think Amish recessive. So I did do some research, and in fact there are some recessive forms of Freeman-Sheldon, even though the dominant is the most typical. And now there is DNA testing for the autosomal dominant form. So a lot of things we had no testing for. It was all clinical. And now there's array testing or DNA testing. Almost everything now. Every day there's new stuff being offered. Here's some more kids that have it. You kind of get to recognize it after you've seen a bunch of them. And primarily what we can do for them is, you know, like a lot of physical therapy, some surgery for some of the contractures, obviously for the club feet. Now, this is a little girl that I saw back at University of Virginia way before we had testing available for this condition. But I'll tell you that she had a VSD, small size, mild developmental delays, kind of this pear-shaped nose. Here's a little boy that I saw back in New Jersey that he has a trach because he had a laryngeal web. His hypertelorism kind of looks like his mom, and had hypospadias. He has what's called Opitz syndrome, which is different than Smith-Lemli-Opitz. Here's some more pictures. And now we know that some of the people with Opitz syndrome have a 22q deletion, similar to what we used to call DeGeorge and velocardiofacial. We try to have gone away from using DeGeorge or velocardiofacial because we now know both are caused by a 22q deletion, the same deletion, and it's quite variable. And some kids will have the typical features initially described by Anthony DeGeorge. I'm including the hypocalcemia and the thymus abnormalities and interrupted aortic arch, but then they have the facial features that look like velocardiofacial, or vice versa. So we see a mixture, very variable. We know there are modifier genes, there's regulatory genes. We're still in research trying to find out all the different things. And virtually every system can be affected with 22q deletion, even though cardiac, growth, development, psychiatric, and palate are the biggest things, and calcium. The thymus abnormalities are kind of interesting because if you do, and you know this from seeing a bunch of these kids, if you do laboratory testing, they're off a little bit in their T cells, but when you have the immunologist evaluate it, they're adequate and it doesn't cause them any problem. It's only about 1% of the kids that really have significant immune problems related to 22q deletion. And again, I think most of you know we have a major 22q center here, of which I'm co-director, and with Dr. Kirshner in plastic surgery, who does the palate surgery, and Dr. Bayless, who is the speech scientist that works with kids that have velopharyngeal dysfunction, which is what you commonly see with 22q. So they have very hypernasal speech along with those pear-shaped nose, and they often will have like a tented upper lip with downturned corners of the mouth. So they look somewhat dysmorphic, but you can't always tell by their look. So if there's any kid we see with VPD, we test them. If there's any kid that maybe has some of the symptoms, we test them. So at our center here, we have specialists in all the areas that are specifically the patients are referred to if they have a problem. So like Dr. Moussis in GI, and Dr. Rogers in ophthalmology, and Dr. Curlin in hematology, Dr. Grishkin in ENT. So just virtually every specialty is covered one way or the other. Dr. Garg in cardiology. And we see the patients regularly. They're always seen by the co-directors, and depending on what their needs are, they're seen by others. One of the more interesting things is the neuropsychiatric problems. As they get older, there's a high incidence of psychiatric, like bipolar or schizophrenia. And a lot of the kids will have some autistic features, OCD and perseveration, things like that. It's not uncommon. And they tend to be shorter, although they are not all shorter. And some of them will have growth hormone deficiency, but many will not. Almost all the cases cannot be seen on routine chromosomes, although that's how it was originally discovered. So either an array or FISH is required. Personally, I like to get an array because it can determine the size of the deletion, as well as if there's some other problem that's a phenocopy. You'll read anywhere from 1 in 1,800 to 1 in 4,000. Probably it's between 1 in 2,000 and 1 in 3,000 is the incidence, even though originally it was thought to be really rare. Most cases are de novo, but about 10% are inherited from a parent. Sometimes the parents didn't know that they had any problems. Some have had problems, but they didn't know the cause. We'll see, you've seen this in the NICU, that you'll see a kid born that has a typical cardiac defect, gets diagnosed, and then you meet the mom or dad who seems to be kind of slow and had problems in school in a hypernasal speech. I'm sure you've all seen that because I've seen a bunch of them in the NICU. And as I said, there's quite a bit of variability. And on September 21st, we're having a national meeting here on 22q deletion if you're at all interested in coming. And it accounts for a large number of cardiac defects. And when they've done prenatal studies, of kids that have been picked up with heart defects and normal karyotypes, then 22q deletion was seen in a certain percentage of all of those kids. It's mostly conotruncal heart defects, so those are the typical ones that you would see with 22q. I think in our NICU, the most common thing we see with the 22q is TETs and VSDs. So this is just to remind you how FISH works, which is one way to diagnose this, although, like I said, I'm getting away from that and more often preferring to get an array. So what FISH stands for is fluorescent in situ hybridization. And what you do is have a probe with fluorescent attachment to it, and what it will do is the probe anneals to a specific genetic area. And in this case, they used the green fluorescent one to just show you this is the 22 chromosome, and that's the one on the bottom. And then they used one with the pink fluorescence, which looks yellow in that picture, but you can see on the real FISH, it's pink. That's the area where you're deleted if you have 22q deletion. So if you have 22q, this is the normal one. So if you have 22q deletion, you'll still see the green, but you won't see the pink. And here it is right here on this slide. So that's when you order the FISH test, what they do. And if you don't ask for it, they don't do it, just so you know. So this isn't a baby, but I have more pictures of babies. And these are all the same diagnosis. Here's a baby. So one of the things that I think sticks out on this baby, kind of puffiness around the eyes and the stellate pattern of the iris. And what these kids all have in common is Williams syndrome. So they kind of have a typical facial appearance, although often as a newborn it's hard to notice. But I have seen kids with just about every kind of birth defect imaginable. I've seen anal stenosis, I've seen atresia, I've seen other heart defects other than supravalvular aortic stenosis. I saw a kid in our NICU here years ago that had pulmonic stenosis, so obviously we were thinking Noonan, but the kid ended up having Williams, because when I saw him back in follow-up, that he looked like a typical Williams syndrome kid from his features. So they all tend to be short with cognitive impairment, and those are the ones that you read about, cocktail personalities, cocktail party personalities. So they tend to be overly social, even though they have cognitive impairment. And they can have hypercalcemia, and it's important to check for that because they do need to be on special formula and followed by renal if they do have hypercalcemia. It is an elastin gene deletion, and it would be picked up on an array if you did an array. So you're seeing some kids that are picked up where you're not suspecting it, but there are problems. But when you suspect it, there's a specific probe for the elastin gene. And that's just showing a picture of the submicroscopic deletion. And here's more kids with Williams syndrome. A lot of them are babies. A lot of times the rightest newborns in the first week, the faces are not obvious, but as they get a little bit older, they're really obvious. So this is a baby that's being fed with a G-tube. So that gives us a hint that maybe he's not a good eater. And if you look closely, you kind of see these funny shaped eyes and a high forehead with bitemporal narrowing and kind of long tapered fingers. And he has Prader-Willi syndrome. So Prader-Willi syndrome should be way up there in your differential on the hypotonic newborn. And again, we have a Prader-Willi clinic center here, and I'm co-director of that with Dr. Rapask from endocrinology. And we start these kids on growth hormone right away, and it's not for growth, it's to increase their metabolism, and it really helps with their muscle tone, which actually helps with their development. And we did a poster that I presented at the genetics meetings, and one of the fellows presented at the endocrine meetings, that the kids that got started in growth hormone early on had a better outcome developmentally than kids that got started later, who still had a better outcome than those kids that didn't get growth hormone. It's caused by a deletion. Well, I shouldn't say deletion. It's caused by missing the dad's a small part of 15q, and that could be missing by a bunch of different processes, most commonly a deletion. But it could be that you have 2 copies of mom's and none of dad's, and that's called uniparental disomy. The region is very close to the area for Angelman syndrome. So the first test that we get when we suspect this is called methylation studies that will tell you if you are missing the dad's or the mom's part of that 15q. It won't tell you if you're missing it because of UPD or you're missing it because of an actual deletion, but there's further studies we can do. And the reason it makes a difference if it's a mom or dad, let me just review what Angelman looks like. Unfortunately, in the newborn period, they don't have distinctive findings like Prader-Willi, but here is a baby that I diagnosed with Angelman's that ended up getting an array, and we found a 15q deletion, and then we had to go on and just find out if it was mom's 15 or dad's 15 missing. And that, there's really nothing specific about this baby. However, they are much more significantly affected as they get older. It's called the happy puppet syndrome because they smile and laugh inappropriately, and they have ataxia, so they walk like a marionette, and very severely cognitively impaired and bad seizures. This is just showing that area of chromosome 15, and the gene for Angelman is called the UBE3A gene. So some of the kids actually have a mutation in the gene that don't have a deletion or the uniparental disomy. With Prader-Willi, we haven't found any gene deletions. It's either deletion, UPD, or something else called an imprinting center defect. So the reason it makes a difference if it's mom or dad's is that certain parts of your genome, not your whole genome, but certain parts are imprinted. And what that means is you kind of start over when the embryo's made, and if it came from mom, there's certain genes that are turned on and certain ones that are turned off, and from dad, certain ones that are turned on and turned off. So in Angelman syndrome, the imprinting center needs the mom's turned on. With Prader-Willi, it needs the dad's turned on, but they're not the same gene, they're just really closely related. And this shows you what percentage have it due to a deletion versus UPD versus other causes. So with Angelman syndrome and Prader-Willi, 70% of them are caused by an actual deletion that could be picked up by FISH or array. With Prader-Willi, 25% are associated with maternal UPD, and let me just show you how that happens. This is the most common way that you get 2 of mom's and none of dad's. It's maternal non-disjunction that leads to trisomy 15. Trisomy 15 is lethal, so the body tries to correct it by doing something called trisomy rescue and losing one of the 15s. And if it does that and it loses one of the moms, then it really rescues and the baby's fine. A case is presented at the meeting several years ago when a woman had early testing and had a trisomy 15, and then she didn't miscarry, and then they tested again, and then she had 2 15s, and they were able to show that they both came from mom. So that's the most common reason that you have maternal UPD, which causes Prader-Willi. So based on that, you can imagine that that is associated with advanced maternal age, the same as Down syndrome or other trisomies. We haven't found any gene mutations, but we have found imprinting center abnormalities that have caused Prader-Willi syndrome. With Angelman syndrome, there's actually gene testing. It's the UBE3A gene, and we can test for that. So if it turns out they don't have a deletion, they don't have UPD, we can test for the gene. If it is deletion or UPD, which most of them are, then the risk to the sieves is very low. But if you have a problem with the imprinting center, then the risk could be as high as 50%. So that's why it's important, once you diagnose by methylation studies that you have Prader-Willi or Angelman, you need to go further to determine if it's FISH, UPD, or imprinting center. Here's how we first found out about that. There were some people that had chromosomes that they could actually see the deletion. I mean, no one would ever order chromosomes if they were suspecting Prader-Willi now, but that's how we first found the deletion. So now the first test you would do is methylation studies. This is a baby. Well, he's older now, or she's older now, sorry. But when she was born, she was noted to have that ginormous umbilical hernia. She had macroglossia, macrosomia, and hypoglycemia, and she has Beckwith-Wiedemann syndrome. Here's another baby with the macroglossia and that really big appearance. Typically, they'll have creases in their ears like you see on this kid. A lot of times they'll have hemangioma or vascular malformations. Here's a big tongue. This was in a paper that we published from when I was at University of Iowa, that before we knew what caused Beckwith-Wiedemann, that we found that there was an unbalanced translocation from the dad causing a duplication in the 11P area, which turns out to be the area of significance for Beckwith-Wiedemann syndrome. Some more hemangioma. Here's the clinical features. I think everybody's familiar with this. And there's a lot of genes in this area on 11p15 and a lot of imprinted genes that we just talked about. Certain genes turned on if it came from mom, certain genes turned on if it came from dad. So it's changes in those genes that actually cause Beckwith-Wiedemann, although in a small percentage you actually have a physical chromosome abnormality like that first paper that we published. And now we have a lot better molecular testing where it can test for everything. We send that to Toronto Sick Kids for that testing. And they can find out in 10 to 20% of the cases you'll see paternal UPD. There's mutations in genes in that area. Some may be familial, some may be sporadic. And it's all involved with overgrowth. So you can see again, pink is mom and blue is dad. Certain genes are turned on from the dad and certain ones are turned on from the... Help interpret it at Toronto Sick Kids. So even though it's a fairly easy clinical diagnosis, it isn't always. I've had kids that are very subtle. This is just showing what's normal, that the IGF-2 gene is turned on for dad and off in mom, and the P57 is turned on in mom and off in dad. Both are involved with growth, and by having a change in that, you get overgrowth. Oops. And so we monitor those kids. The first 8 years, they get every 3-month ultrasounds of their abdomen because of the increased risk of embryonal tumors. And they also get AFPs for the first 4 years. Then primarily after that, you're getting renal ultrasounds because you're primarily worried about kidney tumors, the most common being Wilms tumor. And we like to monitor these kids after 8 years. We do it every 6 months, and then in high school we do it once a year. And once they finish high school, we stop monitoring them. We're having some better results now with coordinating the actual molecular abnormality with the risk for tumors, but for now we're doing the monitoring for all kids, whatever the cause of the Beckwith-Wiedemann. But I would say within the next couple of years, it can probably be customized depending on what their molecular defect is. Now, here's a baby. I'm sure you've all seen a baby that looked like that came to your NICU because he or she was really tiny, probably had a heart defect, had this kind of face. That they were very hairy, had synophorus, upturned nose, downturned corners of the mouth, and had small hands and feet or missing hands and feet. Here's a picture of another baby. Here's someone, an older kid that's missing the distal part of the arm, and you can see how hirsute these people are. So that's Cornelia de Lange syndrome. I'm sure everybody here has seen somebody with Cornelia de Lange. They're pretty easy to diagnose clinically. They all have fairly significant cognitive impairment. They usually don't learn to walk or talk. They all have small size. Most of them have some type of limb defect, even though it might be small hands or feet. They're all hirsute with synophorus. And we now have molecular testing. It doesn't pick up 100%, but we do have genes that we can check for DeLange syndrome. Like I said, everything we were used to be able to diagnose clinically only, so no one could call you if you were wrong because you didn't have any way to prove it one way or the other. Now they can call us on it. So these are two genes. The 50% will have a nibble gene abnormality, and a small percentage will have this SMC1L1 gene abnormality. Almost everyone that has DeLange is de novo, but we have seen some more mildly affected parents very rarely. This is, at this point, a stillborn or fetus that has, this in the back is an encephalocele. You can see the club feet and the big belly. Here's a close-up of the encephalocele, and if you count the fingers, you can see the baby has polydactyly. And if you see the big belly is due to polycystic kidneys. So polydactyly, polycystic kidneys, encephalocele, that's called Meckel-Gruber syndrome. And we now know that Meckel-Gruber syndrome is caused by ciliopathy, and that's fairly new stuff. And there are multiple genes that we can test for now. It used to be prenatal testing was by ultrasound only, but now there's a lot of genes that we can check for to pick up Meckel-Gruber's. It's not 100%, but we keep getting more and more. And it is autosomal recessive. So if a couple has a baby with this, then that same couple will have a 25% recurrence risk. And the carriers themselves don't have anything, so you find out about it once you have an affected baby, unfortunately. So we're not doing carrier testing for that as a routine thing. I'll just show you a bunch of pictures of kids. And this kid's kind of coarse, short neck. Here's another one, coarse, short neck, downward slant to the palpebral fissures, often have posteriorly rotated ears. Another one really coarse. And we see a lot of kids here with Noonan syndrome. You'll think about it in every newborn you see that either has pulmonic stenosis or the short web neck. The lymphatic dysplasia that's commonly seen gives features that are similar to a newborn with Turner syndrome. So back in the day, when I say back in the day, before some of you were born, they used to call it male Turner syndrome. But in fact, boys and girls get Noonan syndrome. It's an autosomal dominant condition. The primary cardiac findings are either pulmonary valve or cardiomyopathy. And as I mentioned, there's now molecular testing. There's several genes. The first gene we found was PTPN11, but now there's a lot more genes. And they're all in a pathway called tyrosine kinase, and that's how they all come together. Most of the kids that have PTPN11 will have pulmonic stenosis, but not all of them. So depending on what you find, you might direct which genes to test for first. Costello syndrome is always caused by HRAS. CFC is primarily BRAF, but there's other genes as well. I'll show you CFC and Costello. They're just all in the same pathway and they look similar. So here's part of the tyrosine kinase pathway. On the bottom, you see all the different genes involved. We test for all of them here. And they usually will ask you, like, what gene do you want to test for? And you might start with PTPN11 and then test for the others. Leopard syndrome is also in that pathway. It's caused by a PTPN11 gene mutation, and those are the kids that have multiple lentigines. They look like big moles, but they have physical appearance to Noonan syndrome, very similar. CFC, as I mentioned, cardiofaciocutaneous, and also Costello syndrome are in the pathway, and I'll show you. Here's a cardiofaciocutaneous. They tend to be more coarse than Noonan syndrome, and they often have this funny hair. It may be kinky, it may be curly, it's usually kind of thin. You can see the eyes are very similar to what you'd see with Noonan syndrome. Here's a kid with Costello. They tend to be really coarse at birth, and they tend to have the curly hair, and they kind of can get little warty findings on their mouth or through their GI system. Casello's, as I mentioned, it's all the ones that we found a mutation has been an HRAS gene. And these are all genes in the same pathway, and that's why they have a lot of physical finding overlap. So this is a kid with developmental delay, short stature, these really unusual looking eyes with wide palpebral fissures and increased fetal fingertip pads. And this is Kabuki syndrome. So named after their physical facial features look a lot like Kabuki makeup. And they tend to have these large floppy ears. They may stick out because they're so floppy, and the increased fetal fingertip pads. They tend to function in the mild to moderate range of cognitive impairment, and there's now molecular genetic testing for Kabuki as well. These are kids that are also hypotonic at birth, and they tend to have these wide anteverted nostrils, 2-3 syndactyly. They're all having G tubes, and what they have is a cholesterol synthesis problem. So what they have is a blockage in their cholesterol synthesis. So they have low cholesterol and very high 70 hydrocholesterol. And that was found out by Dr. Steve Tint that worked at the VA hospital in South Orange, New Jersey. And now it's become a common test that we do for kids that we suspect have Smith-Lemli-Opitz or other abnormalities in the cholesterol synthesis pathway. These kids usually have very severe MR with microcephaly and myelination problems. The males will have underdeveloped genitalia. We do treat the kids with cholesterol, and it really does seem to help with their behavior. Prenatal available. They were using the testing of the cholesterol prenatally, but now there's DNA testing. Once we make the diagnosis, we can do DNA testing and then test for future pregnancies with molecular testing. This is a kid that has lissencephaly, as you can see on the right side, and this kind of furrow in the forehead. Has a lot of cognitive problems and seizures. And what he has is Miller-Dieker syndrome, described by Jim Miller in neurology at University of Virginia, and later found to be due to a chromosome deletion on 17p. And it turns out that there's other specific genes for lissencephaly in that area. And Dr. Bill Dobbins, who's now at University of Washington in Seattle, has kind of taken over all that research and genes, microcephaly genes. Walker-Warburg, I know we've seen in the neonate. Here it's a rare autosomal recessive condition that besides having lissencephaly has retinal malformations and elevated CK. This kid unfortunately has a bad diagnosis. He's another hypotonic newborn, and you kind of see his sort of high forehead, droopy eyes. Here's two more. They all kind of look alike. And they have Zellweger. Paroxysmal condition. Very long chain fatty acids that we send to Kennedy Krieger Institute. It's also called cerebrohepatorenal syndrome. Really significant hypotonia, really bad prognosis. They die young. We haven't really found a treatment. And there is DNA diagnosis available now. So first we didn't very long chain fatty acids, and now we have well. So it's been here for a while. I've seen some of our babies with Zellweger syndrome. Always sad, always a hard parent meeting to have because of the very poor prognosis. And that's it. Oh, we got through all of these things in 1 hour or less. So let me ask if anyone has any questions and anything I can help you with.
I've been told by your department before, Dr. Atkins, that when we're worried about a genetic that in cost, assuming both versus just one?
Yeah, I can speak to that, but obviously if you're here, what are you going to do? You're going to get a genetics consult. But yeah, there's not that much difference in cost. So when would I get chromosomes and not array? I would get chromosomes if I looked at the baby and said Down syndrome, trisomy 13, trisomy 18, or Turner syndrome. Then I get chromosomes. Otherwise, I get an array.
Okay. But the array without chromosomes beforehand?
No, right, because you're going to pick up everything that the chromosomes would pick up plus more. So the only reason I get chromosomes is, you know, you look at this kid, you really know what the kid has, and it's something easily diagnosed by chromosomes. You could get a, you know, hopefully a 48-hour turnaround. Just say stat. You have to order it stat in this institution. And, you know, if you want, if you're not sure. I mean, for us, that's when I order it, is when I'm thinking it's probably this. So let's go for where the money is first. And then, if not, we can do an array. But otherwise, I just go to the array because you're going to pick up things that you can't pick up on routine chromosomes. And pretty soon we're going to have SNP arrays available. Have you had your talk yet on lab stuff, molecular and cyto? Craig? No? Coming up. So you'll learn more about that when you have that talk. But we are going to have SNP array, and then I might as well exome sequencing, which on very limited conditions, condition, and you're not going to be able to order it. The way they've worked it out here, it only can be ordered through genetics, and we send it to Baylor, and they worked out a special deal price-wise with them. So it's got to be a really special case. There's a 6-month turnaround. You have to have pre-testing consent, explain everything, and then decide whether you're going to call out the variation carriers that you find out. So it's pretty complicated. So it's saved for really cases where you know it's genetic, but you don't know what it is, and you've tried everything so far, so let's just go for the whole exome. So just so it's in your vocabulary, SNP arrays are next, and whole exome sequencing, they'll be doing it here. Okay, anything else you want to ask about? All right, thank you so much for your attention.